Okay, continuing our discussion with the antibiotics, and the third class of agents that we're going to discuss is the protein synthesis inhibitors. And the whole idea of the protein synthesis inhibitors is going after the ribosomes and inhibiting the protein from being made. Uh, Now, I actually wanted to spend a little bit of time about how to inhibit the ribosomal functions, and the reason why I want to do that is not because I love ribosomes or that I'm fascinated about ribosomes, is because they are super high yield points for step one and maybe your block exams, but specifically step one, you'll get so many questions about where exactly do these medications work in the ribosomes. So if you think about it, how do we inhibit the ribosome function? So the ribosome, if you think about it, first the 30S comes with the 50S, and then you have the initiation complex, and then after that you get peptide elongation, and then you get peptide translocation, and then the cycle keeps going until you make the protein. So you can intervene in every step of this process to inhibit the ribosomes um, from making proteins. So the first thing that we're going to do is that we can inhibit the initiation complex formation. So that's both the 30S and then the 50S. And the medications that do that is linezolid and aminoglycosides. So if you look here at this diagram from first aid, so 50S is right here and 30S is right here. As they come together, linezolid kind of comes in and says, hey, I'm not going to let you bind together. So it stops the 50S from binding. Um, and um, if you don't do that, then the aminoglycosides will come together and then they'll bind the 30S and they'll do the same thing. The aminoglycosides also cause misreading of the mRNA. So that's the first process that you can block. The second process is that you can block peptide elongation. So that's in the 50S ribosome, and that's using a medication called chloramphenicol. Third process that you can block is translocation. So that's moving the growing peptide chain from one side to the other, and this is used. This can be blocked by two medications, mainly macrolides like azithromycin, erythromycin, and clindamycin, and they both pretty much have the same mechanism of action. And the last thing is that you can inhibit introduction of new amino acyl tRNA. So when the growing peptide chain is getting new amino acids, it's using this enzyme amino acyl tRNA, and this medication tetracycline blocks it, and that's in the 30S ribosome. So a mnemonic that first aid uses, and I kind of use it sometimes, is buy at 30, sell at 50. So buy at 30, so at is the aminoglycosides and the tetracyclines, they block the 30 subunits. And then sell at 50, so chloramphenicol, clindamycin. E is for erythromycin, which is representing for the macrolides. And then L is linezolid. Whatever helps you remember it, just please remember where exactly do they bind and what do they block? Because if you remember this, you'll be golden for step. So let's talk in details about these medications, what they're used for, and their side effects. So the first class of medications is the aminoglycosides. So these block the 30S subunits. So names for these medications can be a little bit challenging because they can mimic other medications, but it's gentamicin, neomycin, tobramycin, streptomycin. So they mainly end in mycin, but the one that's kind of weird is amikacin. And how they work is primarily they bind the 30S subunit and they inhibit the initiation complex, like we talked about in the previous slide. Additionally, so you may have this additional effect of misreading of the mRNA and blocking translocation, but the main thing is the 30S subunit. The one kind of caveat about aminoglycosides is they actually require oxygen for the uptake. So if you think about it, the antibiotic needs to get inside of the cell to work. Aminoglycosides specifically needs oxygen to get inside of the cell. So if you think about it, which um, class of bacteria would the aminoglycosides be not effective against? Yes, aminoglycosides. So, sorry, I apologize. Anaerobes. So anaerobes do not need oxygen to survive. So if they do not need oxygen, then um, you're not going to have oxygen, and then you're not going to have aminoglycosides going into the cells. So I hope that point makes sense because that can be a little bit confusing for students. Spectrum for aminoglycosides, it's mainly gram-negative, so a lot of gram-negative bacteria it covers, including Pseudomonas. It can also be used for synergy. So as we talked about, the concept of synergy is that you can use it with another medication to boost its effect. So it's used for synergy for specifically gram-positive organisms like staph, aureus, strep, pneumo, or enterococcus, but use it with other antibiotics. So that's as far as the spectrum. Side effects for aminoglycosides is very important. So kidneys, ears, and muscles and babies. Kidneys, ears, muscles, and babies. So first thing is kidneys. So aminoglycosides are notorious for nephrotoxicity. And the mechanism of nephrotoxicity is that they can cause acute tubular necrosis. So they accumulate in the tubules and they cause the death of these tubules. Fortunately, this is a reversible side effect with with stopping the medication, but it's something that you have to be aware of clinically and on exams. The second side effect is that it can cause ototoxicity. So it causes loss of hearing and it damages the hair cells. And the high frequency is lost first. This is not a reversible side effect. Another example is the loop diuretics. So loop diuretics cause the same side effects. Third side effect is neuromuscular blockade. So they actually go into the muscular junction and they cause a neuromuscular blockade. And the last thing is that it's a teratogen. But if you're going to remember anything, I would highly remember nephrotoxicity and ototoxicity. I would also remember how it works, binds 30S, and requires oxygen, covers Pseudomonas, and synergy for gram-positive. So that's aminoglycosides in a few words. Second class of agents is the tetracyclines. So these also inhibit the 30S. Example for it is tetracycline, doxycycline, and minocycline. And how they work is that they bind the 30S, as we talked about, and they prevent attachment of the amino-acyl tRNA to the A site. So this is the new tRNA that's bringing the new amino acids. Tetracyclines are especially effective against intracellular pathogens. And they're used for a whole bunch of things. I don't want to go into too much depth in it. You'll cover it in micro. But many zoonotics, a lot of like the atypical bacteria. Doxycycline is also effective against MRSA. But again, this is something that you don't need to worry about too much right now because you'll cover it again in micro. Side effects for the tetracyclines, the ones that I would remember, is they can cause discoloration of teeth in children. I actually had one of my step 1 questions was on tetracyclines. It gave me a baby with discolored teeth, and it was asking me what is the one medication that the mother was taking, and the answer was one of the tetracyclines. It also causes inhibition of bone growth in children, and it causes some photosensitivity. So for all of these reasons, it's contraindicated in pregnancy. Also, like the fluoroquinolones, it chelates with antacids, so you don't want to give it with milk or antacids or things like that that can bind to the tetracycline. So if I would remember anything about the tetracycline, 30S, intracellular pathogens, discoloration of teeth, and inhibition of bone growth, and you would be golden. The next cousin of tetracycline is tigacycline. So tigacycline is a tetracycline derivative, and it has the same mechanism of action. If I would describe tigacycline in one word, I would call it pretty much the biggest gun of antibiotics. It has the broadest spectrum out of all the antibiotics. Gram-positive, gram-negative, anaerobes, you name it. Covers MRSA, covers VRE, so it has the biggest spectrum. The only thing that it doesn't cover is Pseudomonas. Next, agents of protein synthesis inhibitors are 50S inhibitors, so chloramphenicol and clindamycin. So chloramphenicol, it blocks the peptidyl transferase at 50S, so it blocks the protein chain elongation. The uses, I wouldn't worry about it too much because it's not highly tested. The side effects ones, the ones that I would actually pay a little bit of attention to. So it can cause aplastic anemia, and it can cause this weird side effect called gray baby syndrome. And the whole idea of gray baby syndrome is that babies, as you know, lack the enzyme uh, that conjugates bilirubin. So this enzyme, it's called UDP glucuronidase transferase. So interestingly enough, chloramphenicol is metabolized via the same enzyme, and chloramphenicol is gray colored. So if you give babies or their mothers chloramphenicol, they're not going to be able to metabolize this medication, and it's going to accumulate in their extremities. So that's how we got the name gray baby syndrome. So that's one side effect that's kind of weird. So examiners like to go after it. They like to go after these, strange side effects and maybe the mechanism for it. Next medication is clindamycin. So it binds the 50S and it blocks translocation, which is pretty much the movement of the newly made peptide from the P site to the A site. So clindamycin, translocation, chloramphenicol, chain elongation. Clindamycin is used for anaerobic infections. So this is something that I would actually remember. So Bacteroides, Clostridium, things like that. It's caused for aspiration pneumonia because that's when anaerobes get into the lung. Lung abscesses and oral infections, all consistent with, anaerobic picture. It can also be used for group A strep. The biggest thing that I would remember about clindamycin is that it's notorious for causing pseudomembranous colitis. So this is an infection of the colon caused by Clostridium difficile. And they call it pseudomembranous is because the colon gets these like formations, like these thickening that looks like a membrane, but it's not really a membrane. It's just a reaction to the bacteria, and it's caused by C. diff. So clindamycin is highly notorious for C. diff. You'll see it on rotations, but it's very, very high yield for exams. Next agent is linezolid. So linezolid is a 50S inhibitor. So it binds 50S and prevents formation of the initiation complex. It's used against vancomycin-resistant enterococcus and MRSA. Side effects for linezolid is kind of weird. So linezolid can cause bone marrow suppression, especially thrombocytopenia. And the one that I would actually pay attention to is serotonin syndrome. And the reason why it causes serotonin syndrome is because it's a weak monoamine oxidase inhibitor. And I don't know if you guys remember, but we talked last exam about monoamine oxidase, and we said that this is the enzyme that metabolizes the monoamines like dopamine, norepinephrine, serotonin, things like that. So if you give linezolid and if you inhibit this enzyme, you're going to get too much serotonin. So I wanted to highlight a little bit about serotonin syndrome because it's going to come up more and more. So I wanted to lay the bricks in your brain about what is serotonin syndrome. So it's caused by any drugs causing an increase in serotonin. The symptoms for it is pretty much excitation. So anything that's excitatory. So hyperreflexia, diaphoresis, diarrhea, because there are serotonin receptors in the gut, and agitation. And the treatment for it is a serotonin antagonist, which is called cyproheptadine. So, and cyproheptadine is actually an antihistamine, but they found that it has serotonin antagonism properties. However, for the purposes of this block exam for linezolid, I would remember serotonin symptom, and I would remember where it binds. Next class of agents for the protein synthesis inhibitors are the macrolides. And the macrolides are sort of like the workhorse of antibiotics. They are They're very commonly used, especially azithromycin, and you'll see it all the time. So classic for it is azithromycin, clarithromycin, and erythromycin. They work by binding to the 50S subunit, but specifically the 23S ribosomal RNA. So that's a little bit of specification to it, and that blocks translocation. It's used for atypical pneumonia, so like mycoplasma, chlamydia, legionella. It's also used for chlamydia and other stuff, but I wouldn't worry too much about it right now because again, you'll cover it in micro. Side effects for macrolides, the two biggest ones that I would remember is first thing, it goes after the gut. So there is specific receptors that macrolides attach to in the gut. I forgot what exactly they're called, but it causes motility of the GI tract. So if you actually have a patient with gut motility issues like diabetic or patients that can't move their gut, you can actually give them a macrolide, not for the purpose of an infection, but for the purpose of moving their gut. So macrolides are used for that, specifically erythromycin. The second side effect that I would remember that I would also be high yield is QT prolongation. I'll ask you guys a question. Do you guys remember which other drug that we talked about recently that that causes QT prolongation? Fluoroquinolones, yes. So fluoroquinolones and macrolides cause QT prolongation. Very, very high yield point to remember. And that concludes our discussion with the protein synthesis inhibitors.